So lastly, for the session, we're going to have a talk by Ray Lee, who's an assistant professor in Department of Radiology at UNC. It's not that many years ago when people started putting PET scans and CT scans together, and that really allowed major changes in localization. Now there's the capability to put PET scans and MR scans together, and Dr. Lee will tell us if it makes any sense, right?
The advantage of speaking last about the most expensive technology possible here is also that everybody else has spoken about everything else interesting. So I could literally take Dr. Hyslop's and Dr. Wong's, put them together, and essentially I've got most of my talk. Thankfully, there's still some interesting things in terms of integration, and I want to thank the committee for allowing me the chance to talk about our new device that was just recently installed at the BRIC, a little less than, well, just this year, and the fourth in the nation, which is a full PET-MR scanner. We'll come back to that in a second. I'm very interested, as sort of the PhD side of me and also the MD side of me, in making sure that the imaging tools that we use can actually, or are of actual benefit to patients. And so, hence my title, since I often accuse the PhDs, including myself, that we're just looking for nails most of the time. So in terms of going with the tradition now of following the historical areas, or looking back at the history, the evolution of PET, of course, PET was invented in the 50s and 60s. Conventional devices didn't really start occurring until the late 1990s. Townsend and Nutt was credited for the first integrated PET-CT scanner. This is sort of at the early part of my PhD, and so during, actually, as I attended multiple RSNAs, our big radiology meeting, all of a sudden PET-CT was introduced in 2003. This is to differentiate itself from a standalone PET unit, and by 2004 the majority of PET scanners were sold with a CT, so that sort of reflects the importance of the anatomy component to be added to the PET component. Practically, the other major reason, besides making it easy for us to interpret the images, is the attenuation correction that's needed by the PET in order to do quantitative PET imaging. PET-MR was actually described in 1997 or earlier. 2006 was the earliest demonstration of a simultaneous acquisition. We'll talk about why that was non-trivial. And 2011, of course, is the FDA approval of the fully integrated PET-MR system. I'm a little biased to our Siemens system because it is a fully integrated system, but you'll see why I think that's sort of important. Approaches to PET-MR, of course, first of all, that we can use a common patient table approach. The Philips Ingenuity TF device, which is one of the first sort of commercially available PET-MR combined systems, basically takes a patient table that you can slide onto the PET side here and then slide into the MR side of things. GE has proposed a similar system now with a PET-CT and MR, so one can argue if this is a PET-CT MR, now 3 modalities. But in essence, they do the exact same thing, which is basically that you have 2 physical systems. The advantage is that in terms of integration, you don't have many of the integration concerns physically, where the MR remains fully shielded. It shouldn't interact too much with the PET scanner, which is located far enough away. And in the grand scheme of things, while there's a lot of engineering involved, there's really minimal integration issues. And there shouldn't be any significant crosstalk between the 2 devices because you're never going to be acquiring from one device or the other device at the same time. Disadvantages, of course, in an era where space obviously remains important, all of a sudden you've got to take up 1 patient in the area where 2 scanners need to locally reside. You have to have the shielding considerations for both the nuclear medicine side, radioactive shielding, plus the MR shielding. That becomes very expensive and non-trivial for such a large area. And like I said, my bias is that this is not true simultaneous acquisition, so therefore are you really taking advantages of both modalities? To take a step back, what about performing simple fusion? We often obviously fuse the PET side of things with the CT that's automated in the workflow in the nuclear medicine reading room. But when we looked at it, we actually did a retrospective study with a medical student working closely with me and looked at, because I'm biased from the neuroradiology side of things, brains for which we happen to have enough of the PET portion covering the brain to be interesting. And so we went back and looked at a large number of studies to identify cases like this, and this is just one example. We have a T1 post-contrast MR image, the PET image, I've not included the CT, and then we fused them together. This took, after finding the actual cases, these are brain mets from the lung primary, but the actual time to do this was less than 5 minutes using existing software that's sitting right there on the computer on the nuclear medicine workstations. Obviously, in terms of cost to the institution, it's almost non-existent, and it just becomes either technologist or radiologist time. So the capability of performing simple perfusion exists, and I'd be hard-pressed to believe that not every single person who's at a medical institution right now does have this capability. It just might be hiding under a leaf somewhere, and probably known to the physicists, but at least to the nuclear medicine side of things. So this is relatively straightforward. So obviously we want to go beyond this to justify a multi-million-dollar device, and to also look for new applications. So what's the actual problem, of course? This is about the rough size of a normal PET scanner. This is the rough size of a pretty conventional MR scanner. We've got to somehow take this entire PET scanner and squeeze it into something that's going to fit within the MR scanner because of the attenuation of the helium bottle that surrounds essentially the coils on the MR scanner. Obviously, we can't put the PET scanner surrounding the MR scanner, so that's the actual physical problem. It turns out there are other barriers to full integration. There's an intense magnetic field, obviously within the MR scanner, and so the PET detectors and electronics need to be magnetically shielded or not be sensitive to the magnetic fields. A huge issue, which probably will turn out to be the 800-pound gorilla in the room that people are paying attention to but trying not to talk about, is that we don't have great methods for PET attenuation correction. It turns out, even though that on the PET-CT side of things, normally we use the CT for the attenuation correction, but unfortunately we need to derive these for the MR sequences. And essentially, the greatest attenuation comes from bone. As all of you know, MR visualization of bone, or at least cortical bone or hard bone, basically, is poor at best. And so therefore, we really need to do a full paradigm shift in terms of how do we approach MR acquisitions in order to provide appropriate quantification on the PET side of things to derive the attenuation. Additionally, one other thing that we've sort of encountered as we've learned about the system is that everything in this photon path needs to be accounted for. What's already been done partially to a certain extent is MRI coils, for example. Dr. Heislip showed the breast coils. Well, you have to have attenuation correction for the breast coils if they're going to be inside a PET MR. But simple things, as simple as headphones, need to be accounted for. If you place headphones around somebody's brain, that needs to be accounted for in terms of the attenuation correction. So never mind EKG leads and things like that. We can sort of avoid some of those things, but anything more substantial needs to be accounted for. So on the MR acquisition side of things, it's not simply a PET and an MR acquisition. There needs to be forethought into how you integrate the two scans simultaneously. The patient is giving off radiation because of the PET injectable tracer, but the MR sequences need to be timed or tuned so that you're acquiring appropriate motion information when needed and things like that. This is very, very ongoing as the recent sort of PET-MR focused meetings. And once again, these are also usually the areas of weakest for MR have been also the areas of traditional CT strengths. Classically, PET-CT is great for lung cancer. Unfortunately, that's exactly where MR is relatively weak. The same for the bone. The key enabling technology that's allowed simultaneous acquisition of PET-MRs has really been these avalanche photodiodes. I'm not going to go heavy into the physics, but basically these can operate in a high field environment, and they're much smaller than conventional photomultiplier tubes. Typically, photomultiplier tubes are 4 to 5 inches long as a minimum, never mind the full support electronics. If you were to take a ring of those and put it inside a scanner, you can imagine how little space is left. These are the current avalanche photodiodes. You can see this is 32 millimeters in dimension here. These are it right here, about 2 millimeters in depth. The reason I like this picture is because it also shows that these things, the APDs, require integrated cooling channels to operate. The MR is cooled itself, of course, because of the superconducting helium down near 0 Kelvin, but unfortunately the APDs themselves also require cooling, and though not to as low a temperature, this has become a failure mode for many of the MR scanners that we've learned about. There's some simple driver boards and electronics that need to sit close to the APDs, but that's a relatively straightforward area of development. These APDs provide direct readout. People have tried other techniques to integrate the systems, and it turns out this is the key technology that's really allowed the development of a truly simultaneous PET-MR. This is a cutaway for the inside of the Siemens Biograph MMR. The RF coil that sits normally close to the patient to generate the MR signal sits here. The APDs sit in a layer beyond that, and then the standard gradient coils, which allow spatial localization, sit beyond that. And so this is a picture of our PET MR scanner. This is one of our technologists giving a sense of scale. It obviously looks like an MR scanner. Well, essentially all scanners to me look essentially the same these days, but it's just a little more bulky. The bore size, they used a large bore MR to begin with and then took away some of that space. So it still can fit larger patients. In the state of North Carolina, however, there are still a high enough percentage of patients that don't fit in this scanner or our other scanners. But that's what it looks like. I want to give you some examples of both images acquired at UNC and some other institutions. This is from a study by Dr. Chera and Ben Huang from our department of head and neck cancer imaging. This is a PET-fused PET, FDG PET, and T1 post-contrast image. This is the actual separate PET image, so we know what it looks like. This is the T1 post-contrast and the T2 image. The key that you're looking at, the little hot spot, which I think everybody can see, is actually a little lymph node in this patient. So this gives you an idea of the fusion of the exquisite anatomy that is available from MR, and then obviously the functional imaging that comes from the PET side of things. Borrowing from Dr. Drezga in Germany, the German it's sort of interesting how they funded their research into the PET-MR side of things. Apparently, quite a few institutions have PET-MR devices, and the way it was described to me was the government said, work together. We'll give you lots of money, but you have to work together, and therefore the Germans have been some of the most productive in terms of looking at PET-MR in terms of new application, things like that. This is an example from Dr. Drezga of lymphoma within the neck, showing both the CT, low-dose CT, fusion of the FDG and CT image, demonstrating this large sort of lymph node mass on the left, patient left, and then on the a smaller lymph node on the right. Obviously, with classic CT, especially low-dose non-contrast, we know the lymph node's there because of mass effect, but it's obviously very hard to see. Once we use an MR instead that gives us better anatomy, the T2 weighted image demonstrates the node very clearly as a very, very bright image, very bright area on the image, and the same for the opposite side. And we can see that those nodes are obviously lighting up also. One should ask immediately, well, what's the difference in separating two scans and then fusing them together? And at this point in time, my opinion is not a whole lot, since we're taking advantage of the anatomy, but there's no reason temporally that they can't be acquired separately and then fused together afterwards. In terms of body imaging performed at UNC thus far, this is Dr. Rathmel's small pilot study looking at renal cell cancer, a combination of basically the MR imaging combined with the PET imaging provide additional information for either staging or characterization purposes. T2 weighted image, we have a large renal lesion, that's the kidney in circumference, and that's the lesion taking up, or at least in this plane, most of the kidney. You can see that actually there's PET uptake, but this is in the collecting system, the calyces of the kidney, pre and post contrast MR that demonstrates obviously the enhancing normal parenchyma and then the renal lesion within it. So this is an example of simultaneous imaging in an area of the body that CT is strong, but I think MR still gives us more anatomy and anatomic information than classic CT. Here's an example from Germany once again of where I would assume as a first path that we have weakness on the MR side of things. This is melanoma metastases to the lung. This is the FDG. This is the low-dose CT, where we can obviously see a mass lesion that also is lighting up when we look at the fusion with the FDG PET. We can use some of the newer novel MR sequences that allow better lung imaging. Classically, obviously, we don't image the lung because of the susceptibility artifact, but because of the same sequences that allow us to image the bone better, also allow us to image the lung better, that the fusion image on the PET MR allows us to see the lesion almost just as well, I think, and clearly with the PET information that we know it's an active lesion and a lesion of concern. So I think from this aspect of things, actually, in terms of whole body screening, looking at some of the classic capabilities from the PET CT side of things, that MR isn't far behind, especially for screening for metastases, even across the body parts that are generally difficult for MR classically. Here's another example of how we can really, I think, start to take advantages of the MR side of things. This is just a stereoaxial image demonstrating a lesion at the left base of tongue. You can see how bright it is when it's fused with the MR PET. This gives us anatomy. On the CT side of things, you would just see slightly more bulky mass in this region, and this is a lesion better directly visualized. The advantage, of course, Dr. Hyslop also alluded to, is that we can incorporate diffusion-weighted imaging and look at that and also get an idea that there's restricted diffusion, suggesting that there's a hypercellular mass in that region. So this is taking advantage of the additional capabilities that Dr. Hyslop also alluded to, delivered by MR, and then enhancing that with functional information given by the PET. So I'm very glad Dr. Wong went through the tracers, so I don't need to. The two ones that we use most often are FDG and sodium fluoride for bone metastases. There's lots of other ones that are up and coming. Given the fights associated with Amivid, and that's an Alzheimer's imaging agent, I'm sort of wondering how long it'll be before we have these available on the clinical side and not for the research side of things. But I think there's still a lot of potential to look at looking at tumor progression and biomarkers of treatment effect using some of these agents. Thankfully, the neuroendocrine DOTATOC PET was already alluded to by Dr. Wong, which saves me time. But here's basically a conventional PET CT image where we see on the PET imaging with a neuroendocrine tumor that lights up brightly here. It's very, very hard to see by conventional CT. The fusion suggests that there's a lesion there, but that may not be sufficient for a surgeon to have a hard target. MR imaging, I think, displays the lesion somewhat better so that we can localize the lesion somewhat better with a fused PET MR combined modality. I think this offers the surgeon somewhat more information, and obviously we have something to follow up with on the MR side of things also. But this is an example of using novel tracers in the PET-MR situation. So these are my 2 cents of the true nails in oncology. I'm speaking more broadly only because there's such a wide variety of sort of primary cancer specialties in the audience, but really, I think we really can use it to enhance some of the strengths of MR, take advantage of the strengths of MR combined with the physiologic information offered by the PET. First of all, soft tissue imaging, abdomen and pelvis classically are very strong strengths of MR. A lot of our initial studies that are being performed at UNC are going to focus on these areas. Musculoskeletal, I think, is an area that's often sort of overlooked to a certain extent, but I think the exquisite ability of MR to identify lesions allows us really a lot of opportunities. This includes spine and of course, my bias is in the brain. I've noticed that pretty much nobody's really shown a lot of images of the brain for classic reasons. I think FDG PET isn't as useful in the brain, but I think looking at brain metastases and looking to the future, there's a huge area of opportunity there. Partially because of this, which is the blood-brain barrier, and that MR is exquisitely effective at measuring that directly. And so we can take that information and combine it with the PET kinetics and offer much more information by combining sort of the physiologic MR and the functional imaging of PET to really perform true quantitative imaging. The obvious application, I think, which unfortunately doesn't bill as well, is pediatric imaging. Essentially, the PET-MR removes the CT radiation dose completely, so therefore the total dose of the patient is roughly half. Obviously, if we're following up children again and again and again, this is a huge issue. One thing that's overlooked even by radiologists is that the age at which your radiation sensitivity drops to a flat line is actually at the age of 35. This is much higher than most people expect. There's a nice New England Journal article that talks about this, and I try to remind our residents whenever teaching basically that we need to be cognizant that radiation sensitivity falls at such a late age and not age 18 when our protocols change over to adult protocols. There's a trade-off of mildly increased scan time, but I think it's worth it for the reduced radiation dose. So I want us to avoid the nail syndrome. Obviously, a PET-MR is a very expensive device to have to upkeep on both sides of things. The tracers are very expensive, especially for the novel tracers. So we always have to ask ourselves, can simple fusion or advanced existing techniques answer the question? And I think in many cases, absolutely yes. I think as we try to push both fronts, we'll find areas where MR may be sufficient, used in a particular way, and the same for novel PET tracers. Simultaneous PET-MR should not simply be the addition of PET plus MR. I think it should be much greater than that, and obviously we want to be somewhat greater than, the whole should be somewhat greater than the sum of the parts here. There should be, I think, appropriate integration of imaging into trials. I think that's one area where radiologists need to take a much more active role in helping incorporate them in sort of incorporating the useful information that we can deliver, and also providing sort of some logic testing in terms of will radiology or something that we're doing actually answer that question. An important area really that needs to be addressed more carefully, Dr. Wong alluded to it, but even more so for PET-MR, is quantification and specifically the attenuation correction error that needs to be done. There's a lot of good work in areas that aren't close to bone, but at the skull base, areas that I'm specifically interested in, the spine and things like that, quantification remains a major issue. Some practical considerations, billing, how do we charge for a PET-MR? That's a very big question on our side of things right now. There's a lot of education, I think, for complex modalities, as we're sort of learning at our institution. There's patient comfort. I showed Amber without the coils on it, but this is what she actually looks like when she's getting ready for the PET-MR. So you can see it looks like she's completely mummified. And there's obviously a need for a source of tracers, either an on-site cyclotron or a commercial source. So these are just some of the things that we need to consider. I want to quickly acknowledge Dr. Lin, the director of the BRIC, and Dr. Ann for her contributions on the MR side of things. Bryce Kessler has been doing the hard work on the fusion, and the BRIC staff for their work on trying to get our system up and running. Thank you.